It's my great pleasure to introduce David, who's been here in Melbourne just over 9 months. And he's brought a background into the department, I think, which is going to merge with a lot of the existing interests and future ones. Came from a pain research background myself. It's a great way to sort of learn about the brain and mind and everything that comes in through that pain aspect, everything involved, from basic molecular biology to perception, safekeeping. It's all captured in the pain world. And what pain didn't have in terms of scientific sort of endeavour was the stuff from cognition and psychology. So, David worked with the guy who started that, Chris Ecclestone, I think. The whole pain research didn't have anything to do with the mind until the guys at Bath started to look at all these cognitive processes that are involved in these pain states. So it's a great way into the emotional brain because to look at pain. But what are you going to tell us, David?
Well, thanks very much, Francis. Basically, Francis sort of covered pretty much my first slide here. But what I'm going to sort of try and do is I'm going to talk to start with about the work that I've been doing for the 5 years before coming here down at the University of Bath with Chris Ecclestone, who really is sort of the pioneer behind this work. And that's going to take most of the time here in the attempt to sort of develop a standardised and reliable battery of cognitive tasks that show an interruptive effect of pain. We're then going to talk. I will then try and towards the end of the talk tell you a little bit about some of the other work that I did initially at Bath, where we tried to look at this in sort of a more real-world context. And if I've got time to start having to think about how that's going to impact upon some of the work I'm going to do here and some of the things I'm interested in, as well as at the end talking very briefly about something which isn't attention, which is primarily what I've been doing my work on, and to talk a little bit about some work I've done with Ruth since being here on time, and again a little bit of an idea where that work's going. So fortunately Ruth isn't here, so she can't realise how little I know about time yet, so which is always handy. So, to really sort of start with, some of what Francis has already said here is starting to think about how important pain is. Chris always likes to start his talks in a really positive sense by saying that we are born in pain, most of us will die in pain, and we live lives punctuated by pain. And it's a cheery way to get the crowd on your side, and I've adopted it because I like it. But it really is. Pain is hugely important, and I'm going to kind of skip over some of the stuff that if it were Helen up here talking, she'd talk about the negative side of pain and chronic pain and all of these these really bad sides where pain sort of goes wrong, where we end up with problems with the system, where we kind of end up with pathology. I'm really trying to sort of bring pain back as being something which is normal and functional. It's hugely important. The first thing that pain does is it promotes behavioural analgesia. A very nice posh way of saying it stops you doing the thing that's hurting. By having pain, it stops you, running on that twisted knee. It stops you using that dislocated arm. And without kind of engaging in those processes of behavioural analgesia, we end up with sustained tissue damage. It's one of the things that we know from those very rare cases of individuals with congenital pain sensitivity is that they live very short lives. Pain is a great warning signal of harm and threat and everything else. It therefore promotes the healing that that we also need. It gets us back to sort of full health again. And it also has a great educational value. It teaches about all about sort of the dangers in the world. Everyone has a parent who has said that that immortal phrase as their child is crying and running out of the kitchen, they'll learn not to touch the stove again. They'll learn not to go near. It's one of the major ways that we learn about our environment. And without this pain, we end up with a very short lifespan, great degree of tissue damage, and we don't learn about threats in our environment. So pain is a hugely important factor in our lives. So what is the meaning of pain? It's a warning sign of actual or potential harm. It's probably the ultimate threat. There's loads of research out there that that loves to look at threatening words and social anxiety words and faces and pictures of spiders, and you get these wonderful little effects where people show a little attentional bias towards pictures of spiders or an angry person on the screen. It's nothing compared to the level of attentional bias you get to an electric shock. If you want people to attend to a location, start hurting them there, and they'll very quickly start paying attention. Pain tends to sort of be historically considered to be, within that sensory domain. We've got this, this history, and going back to Descartes, and of pain being, a sensory experience. It's a signal comes from the outside, goes up to the brain, and it hurts, and we do things about it. And for a while now, there's been an emotional component to it. People have talked about the fact that, pain makes us sad, it changes how we feel about the situation. But there's a huge cognitive component, and it's a very complex relationship, and I'm really only going to touch on the outside of that for now, and not kind of go into the complex cognitive process of catastrophizing, of so much of the thought process is the way that we can modulate our behaviour and our thoughts in pain. The kind of downsides, the consequences of pain is that in the long term, we end up with kind of pain potentially being very disabling, and we often think of that from the point of view that pain, disables our physical function. Quite easy to see that somebody with a broken leg, somebody with with a problem like that, can't do a number of physical tasks. But actually, one of the biggest kind of disabling factors of pain can be the distress it causes, can be the inability to concentrate, the inability to think. And certainly if you talk to chronic pain patients, often they will say that, well, I've worked out ways around, the physical pain. And I can cope with the fact that I'm in pain. I've dealt with that emotional trauma. It upsets me, but it's something I can manage. But the thing that I can't cope with is the fact that my pain prevents me from working. My pain prevents me from, concentrating on reading books. It prevents me from, we've heard reports, chronic pain patients say, it prevents me from watching the TV. I can't do anything I like to do anymore. I can't do anything that involves, my own cognitions. So, and that's really because pain goes through this process. It disrupts, it interrupts, it's attention grabbing. And in the short term, that's functional. When it becomes long term, it becomes kind of highly problematic. And when I say about long term, that doesn't necessarily just mean, months and years. Once you've got a headache and you're trying to kind of deal with it, you've taken some analgesics, whatever else, it's still disabling you day in, day out. And what we're going to try and sort of, probably skirt around a little bit is what the function of analgesics are. So, analgesics are great at reducing the sensory aspects of pain. They reduce down that hurt, that thing. And again, because we tend to have a very biomedical model here, we want to remove the pain from the situation. But what about the cognitive and emotional aspects? This is what people tend to report as being the problem. So, one thing that we know is that a very effective analgesic is are the opioids. Morphine will deal with a lot of pain, but it won't restore your ability to return to work. A huge dose of morphine is not going to allow me to write better papers. Certainly not. Well, it might mean that I write more exciting papers, but it's certainly I doubt that the journals are going to rate them quite as highly. So it's not going to kind of restore these cognitive aspects that people are reporting as problematic. So if we can potentially come up with analgesics that allow me to concentrate through the pain's still there, but it's not disabling me, it's not disrupting, then that's potentially something which is of huge benefit to the problems that people are reporting. So a little bit about what do we know about pain and attention. We know anecdotally that distracting ourselves from pain reduces the pain. If you think about something else, if you focus on something else, you do experience slightly less pain. We also know that distraction is a part of many of the CBT processes, so using these kind of attentional tasks, not thinking about it, distracting yourself from it, is therapeutically recognised as being a way of managing pain. And I'm not going to get into kind of whether or not it's an effective way in the long term, because that's probably about an 8-hour talk. But we know that kind of experimentally, and kind of as I'm going towards what I'm really going to talk about here, which is experimental pain, that distracting yourself, performing a complex cognitive task when I'm experiencing experimental pain stimuli, so something like a cold presser task, so plunging your arm into water at 2 degrees, which is known to be painful, has certain effects on those ratings of pain. Some studies have found that that it reduces down the amount of pain experienced. A number of them, though, kind of suggest that, again, this is a little bit more complex, and the study particularly cited here found that the participants didn't report their pain threshold as being any different, whether they were performing a complex task or not. They didn't report the pain as being any less when they were performing the complex task, but they were able to endure the pain for longer as a result of it. So it seems to be, there are effects that this kind of distraction has. But I'm not going to be talking about kind of that side of things, but that's where the majority of the literature exists, is using attention therapeutically. What I'm interested really is, as the title kind of suggests, what's the impact of pain? What does it prevent us from doing? And as Francis says, this was a really, given kind of the anecdotal level of finding things hard in pain, you'd think there would be hundreds and thousands of studies out there that looked at this effect, but there really aren't. It's a very, very under-researched field. There's a handful of studies that have taken chronic pain patients, given them, in this particular case, things like the test of everyday attention, so fairly standard kind of batteries of tasks, and found that, yes, they do appear to be impaired on tasks of attention. But there are problems with doing this with chronic pain patients. If you're looking at kind of trying to get a really pure measure, you tend to end up with depression, anxiety, other problems that are going to kind of, sit on top of the actual effect of pain. That and the fact that we don't know the effect that them having a chronic long-term pain complaint is going to have, on their attentional systems anyway. If you're looking at just that disruptive effect in the short term. And there really kind of, is a great limit of research. When we started this process, studies really looking at attentional interruption using standardised kind of cognitive tasks in an otherwise healthy population, numbered around about 4 or 5 that had used anything that really that standardised. And the only research that really existed was using a task that Chris had developed with here at Crombie in Belgium back in the mid-90s, which was the primary task paradigm, which basically consisted of short electric shock at the beginning of presentation of a tone, high or low, and participants had to indicate, is the tone high or is it low? And they found that people were slower and less accurate to do that if at the beginning there was an electric shock with it. And that had been almost all the research that had been done. Since then we started to kind of get into more work, primarily within the lab at Bath, with work I was doing, and the lab out at Ghent, headed by Gert, which has developed this sort of top-down, bottom-up model that started to look at factors that are involved in the relationship. And Lagrange suggested a number of sorts of bottom-up factors that are going to alter the size of the interruptive effect. So the intensity of the stimulus, the novelty of the stimulus, more novel stimuli, higher intensity stimuli are going to have bigger effects, as well as top-down factors that you can use to control pain, so involving the avoidance of harm, the threat value of the pain, and how we feel about it. And the work that they've been doing out there is much more focused on what factors about pain affect the size of the relationship. As I'm going to talk about in a bit, we were much more interested in what sort of tasks, what does pain stop, or what does pain impair. The problem being is that we don't really know how pain interferes with normal cognitive function, or we didn't at the time, and we don't know whether or not analgesics help to combat these effects. The reason for this is that there wasn't a measure of pain interruption, and therefore the obvious solution was to design one. Nice, finding the right tasks. So we started off by trying to find out, what tasks are there out there that we could potentially use. So conducted a systematic review, we wanted tasks that were going to be affected by acute pain in a lab setting. So it's fairly small effects. We can't induce huge whacking great pains in participants because of ethics and participants' tendency to run out of the lab if you try. So we're looking for things that are going to be sensitive to fairly small effects. So we wanted to sort of look at literatures that existed that we could draw upon. And we looked at the literatures on alcohol, caffeine and nicotine to see cognitive effects that these had and tasks that might be sensitive. And we came up with kind of a pragmatic classification for different attentional tasks. I'm going to particularly avoid looking at caffeine at the moment because some of these, we can argue over whether or not they are all really attentional. Some of them have memory components, some of them are executive, and but broadly speaking, they've all been used to be considered as kind of attention tasks as well. And this was the classification that we came up with. We then designed a method for inducing pain, so a model for pain induction. And for our first study, we recruited a total of 140 healthy adults. We determined pain thresholds using a standardised quantity sensory testing protocol, which involves increasing the temperature at a rate of 1 degree per second, waiting for participants to report pain threshold and using the average of 5 trials. Once we had participants' pain threshold, we also determined sensation thresholds, the first sensation they could feel. And we tested people on a whole range of tasks under 3 conditions within participant design, with no stimulation at all, with a warm sensation, so this was presenting heat up 1 degree above individually calculated sensation threshold, so something which was just detectable but definitely not painful. And we asked them to do the tasks under those conditions, and also while experiencing a sensation of pain, and to try and model the real world experience of pain. One thing that we do know with pain induction is that if you just give people a long continuous sensation of pain, people habituate to it very quickly, it stops being felt as painful. So we used a variable ramp and hold procedure, broadly looks a little bit like this, to induce pain, in which there were periods down at the bottom here where the participant experienced no pain at all. This is down at baseline. And then periods of pain included within the task. And what we did to try and keep it slightly unpredictable, because pain kind of waves in and out. You don't know how long it's going to be between the experiences. We used anything between 2 and 10 seconds between pain episodes, and a pain sensation that lasted either 1 or 3 seconds, completely randomly generated. This is what we used for this first task. I'll talk a little bit about the fact that we changed this for the subsequent ones, because the downside to using this method is that there are large periods of time in which participants are not experiencing any pain sensation. So that is a potential limitation in this study. So what were the tasks that we ultimately used? I told you about the classification that we used. We used a continuous performance task, flanker task, endogenous cueing, so on and so forth. And what we found was that the effects of pain were selective. We only got an effect of pain on 3 of our 7 tasks here. So the NBAC task, attentional switching, and dual task. The rest of them we found there was no significant effect of pain on these particular tasks. Because I don't really have time to talk about all of the tasks, I'm going to very quickly just tell you about the ones that we did find an effect on, because those are going to be the ones we're going to use throughout. So we used a 2-back task, quite simply, a series of stimuli presented for about 2 seconds each. And we asked participants to indicate if the stimulus on the screen is the same as 2 letters ago. And if it is, then make a response. If it's not, make a different response. So you can see here, DLD, second D there would be a target stimulus. And this is what we found in this particular task, was that Out of 30, participants were generally getting about 23 correct on when the baseline or the warm sensation was present. But in pain, they sort of dropped this off to about 21 and a half on this. So not a huge effect, but this wasn't reliable. Using attentional switching tasks, this was cued attentional switching. Participants were told one of two tasks to perform with subsequent numbers to indicate either whether or not the number was odd or even, or less than or greater than 5. And what we're interested in here is whether or not if pain influences the size of the switch cost. So again, as you can see here at the bottom, when the task remains the same, so when you go odd even, there's absolutely no effect of pain whatsoever. The effect here is slightly less compelling because what we actually get is that in either the warm or the pain condition, we find that participants are performing significantly slower on the switch trials. So when you go from an odd even to a high-low task. And lastly, we designed, based on the review that we conducted, a dual task which involved participants indicating if there were 3 consecutive odd or even numbers. So 397 there. They had to make a response. Participants also had to make a response if 2 lines on the far left and right hand side of the screen mismatched each other. So you can see on the just the second screen there, that the 2 lines on the far right, left and right are different to each other. And what we found here was, again, slightly complex, not as straightforward as we would ideally like, was that during the baseline and warm conditions, participants found the lines task, so the peripheral task, fairly straightforward, performing up around 75%. And when in a pain condition, this performance dropped off greatly. Just to confuse things a little bit, they actually got better at the numbers task in pain. So it looks as though something's going on here which is not as simple as with, certainly with the MBAC task. What we appear to be getting here is an effect on this task which suggests that they're kind of reprioritising. This task was potentially hard, but it's more central. It's what they're having to focus most of their attention on. So we've interpreted this as being, or certainly in this paper, we interpreted this as being an effect of pain on dual task performance. So they were having to kind of hyper focus on one task at the cost of the other. As you'll see as I continue, this gets nice and more complicated, just to make it fun. So, table I'm going to come back to repeatedly here. Within phase 2, we tested these effects and we found that yes, pain affected the 3 tasks, unsurprisingly, because they were the ones that we selected. So, the first thing that we found is that the effect of pain is selective. It's not as straightforward as some of the previous research had suggested, and particularly given that a lot of the previous research uses the disruptive effect of pain as being a sudden onset, so an electrical sensation, a sudden onset of heat. So it's something, or laser pain. It comes in and it's instantly very painful. It feels like a pinprick, and you find that it impairs task performance. The downside to that is that what you've basically got is a very, very threatening stimulus that doesn't necessarily reflect the real kind of pain that we're really experiencing. Because anything that suddenly happens in your environment is probably going to distract you. A sudden bang is going to distract you, a sudden flash of light is going to distract you. What we're interested here is much more that sort of, like the throbbing nature of pain, that unpleasantness that goes along with it. So that particular kind of pain that potentially reflects acute pain sensations better appears to really be selected for these more complex tasks that are more demanding, that involve the manipulation of multiple cues. And for that reason, we took those kind of good candidate tasks, I'm going to refer to them, and we sort of put those in to be the preliminary parts of the bath tap battery. Bath tap is bath test of attention for pain, and a joke that's only funny the first 2,000 times you tell it, and then it stops being funny fairly quickly after that. So we then took this a little bit further, and we started to test this in different kind of conditions. So we went back to kind of the model by Lagrange, and we started to look at a couple of the things, one about the pain and one about the tasks that might influence the size of the effect. And the first thing we did was we changed the threat context of the pain. One thing that we know about pain induced in the lab is that essentially we stand there with the participant and we tell them it's all going to be fine, it's very well controlled, the equipment's brilliant, it does this in a very controlled way, it's at your threshold, you've got control, big red button stops it at any point. So it really removes that threat value that pain usually has. It's unpleasant, we don't like it, we don't know if it's going to go away. We wonder if we're safe. So we designed a study in which we gave half of our participants our control instructions, that this was safe, reliable, etc., etc., etc. I then used my great acting skills with the second condition, and we first told participants that once they'd determined their pain threshold, we gave them a little sheet to read while we performed some magical calculations that told them all about the negative effects that extreme pain can have on the body. It's all about how extreme pain results in burns, blisters, etc., etc., etc. There was nothing to do with the stimulus that we were delivering. We then told them that the equipment had the ability to determine skin's resistance, which was nice and meaningless, and told them that they were in a high-risk condition, that they had a low skin resistance to thermal stimuli, and therefore they were in a high-risk condition, but just within the limits to allow them to be in it, and we would have to monitor them throughout the study. And we also, knowing that people generally don't like medical things, rather than telling them they were going to be doing a heat task, we talked about the fact that they were going to be doing a vasocontraction task and used lots of nice medical terminology to make it sound much more intimidating and not understandable. The slight downside, I should say that participants universally believed our manipulation. They thought that they were at risk. For some reason, it had absolutely no effect on their level of anxiety. Right? So there is kind of a pre-existing problem with this particular study. But for some reason, people will believe that they're at high risk and that this is nasty and horrible. But for some reason, it doesn't make them any more nervous. So we changed the model for pain here. So rather than having these long gaps between sensations, we used an oscillating pain sensation that just went 1 degree above and below pain threshold, and more or less throughout the tasks. And what we found was that we replicated our effect on the MBAT task. So participants performed worse in pain. Again, we replicated our effect on attentional switching. So participants performed poorer on switch trials when in pain. And we found that there was no effect on the dual task. We also found that there was more or less no effective threat on any of these relationships. And so partly that might be a problem because of the fact that these didn't increase anxiety, and that's really what we were trying to do. But the only effect the threat did have is that threat made people perform worse on the numbers element of the dual task, but that didn't actually relate to them being in the pain condition. When the participants who were in the threat condition just performed worse on that to an equal degree in pain and out of pain, so it doesn't seem particularly meaningful. So we'll skip past that because it wasn't that, it didn't really come out with anything. We then did another task where we manipulated the level of load that was on the task, so does just making the tasks harder influence the effect that we get here. So we did high and low load versions of the tasks. For the MBAT, we were able to keep the task more or less the same, so we did a 2-BAT version, so is the letter the same as 2 letters ago, versus a 3-BAT version, is the same as 3 letters ago. We had to slightly change our other 2 tasks, unfortunately, because they didn't nicely lend themselves to this sort of load manipulation. So we designed a switching task in which we gave the participants a list of either 3 or 8 letters to remember, and then we asked them to perform a task which involved switching between the tasks of was this in the memory list or not, and is the letter red or green. And then we did a divided attention task, which again had to be quite heavily modified to were the 3 stimuli at the centre in the memory list or not, and then the lines task remain the same. So, same pain procedure as we used in the threat study. Again, we broadly replicate our findings on the MBAT task here, slightly confused by the fact that we get them in the 3-back task but not in the 2-back task, as we have done previously. And unfortunately we find no effect on our switching task or our dual task. So these 2 tasks, as I say, were modified. They do look quite different, as in sort of previous ones. But our conclusions here was that our original configuration of the tasks is probably more sensitive. What we actually found mostly with the switching and the dual tasks in this particular study was that there was just a lot of noise in the data. And this seems to be a bit of a problem for our statistics here at least. Slightly confusing given that we get the effect, as I say, on the MBAC task only in the high load condition. That might be something about, because participants perform both the high and low load version here, that those who'd done the high load first were better practiced by the time they got to doing the low load version. But it does seem as though load might be possibly a factor here. So we get the effect here in the attention span task. So we're starting to get to a point where, well, certainly I was losing faith completely in the dual task at this stage, but the others do sort of seem to be, there might be something reliable here, certainly with the attention span. So at the end of this particular phase where we're trying to see what the effects are by kind of manipulating the tasks, we get some indication that our results may replicate. The effect seems to sort of remain despite changing the context, changing how we kind of present the tasks, particularly kind of giving them within a battery rather than on their own. And therefore the next step here is that, as I said at the beginning, what we're interested in is starting to look at the effect that acute pain has on performance. So we're interested in sort of the effects that we all have in our everyday lives, those kind of headache pains, anything else, and how that prevents people from performing normal daily tasks. So the next phase of this particular grant was to make the transition from the experimental pain models that we've used, that I've talked about before, into the everyday, naturally occurring acute pains. So again, the reason for this being that those kind of experimental pains that we used originally, although it is painful, anybody who's been into the lab, in Francis' lab and played with the equipment will know that it is a painful sensation. Anybody who hasn't and wants to take part in something, I'm hopefully going to be running some soon, so if you want to know how it feels, come and find me. But it is a very different sort of pain to that we normally experience. It's on the skin rather than being a much more internal sensation. It's repetitive. It's at threshold. You can stop it at any time. So it kind of just lacks this ecological validity. So we wanted to look at naturally occurring pains. In the finest traditions of these things, we went back and we did another review. And we wanted to find out, were there ways of researching these acute pain conditions in a lab setting which were kind of reliable. And we were interested in 2 sides to this. We were interested in these common acute pain sensations. Is there a way to induce them? So can we reliably induce that exact sensation in a lab setting? And if not, is there sort of guidance that we can use from the published literature for how to reliably recruit people who have these kind of sensations? What we found is that for most of these pains, there was a way of inducing the sensation, but that for the most part, these weren't necessarily the best ways to do this. So for headache, for example, there are a number of drugs that cause headache. There are a number of muscular techniques that you can use to induce headache. These only work in a small percentage of the population. They typically take quite a long time to have their effects, so 24 to 48 hours. And the sensations might not be kind of qualitatively the same as they are when they kind of naturally occur. And given the frequency with which headache is experienced, there's no real good reason to induce headache when you can just kind of get people to come in when they have one. The one pain sensation that there was no way of inducing was menstrual pain, and this is where I'm glad that I'm nearest the door. Fortunately, there's no need to, because menstrual pain from a research point of view is wonderful, because it comes around on a reliable cycle. The same people tend to experience it repeatedly. It tends to be fairly kind of predictable and repeatable. Nice 4-week cycle allows you to do a 2-week kind of separated testing process. Brilliant. Menstrual pain's great. I'll wait to be lynched as we leave. It's all right, Francis, you can stop them as they come past, can't you? So yeah, there is no way to induce menstrual pain. There's no real need to, but it does make a very useful kind of naturally occurring pain model. We found that for induction, that muscular pain, you can do a lot of nice things with delayed onset muscle soreness. Unfortunately, including at least a few people in the room, there are people who strangely do this to themselves for no good reason, who like to go running and do other stupid activities that hurt themselves. We'll never fully understand this, but there are reliable procedures for getting people to sort of run downhill on a treadmill for a couple of hours, and the next day they'll have lovely, delightful pain in their legs, and you can then use that to test with. Muscle pain, as it naturally occurs, is really problematic because it tends to be really unreliable. It's very different kind of sensations, whereas delayed onset muscle soreness is really quite reliable. Again, dental pain, there are ways of recruiting people in, but the sensations tend to be quite heterogeneous, whereas if we use kind of dental induction models, we can get a much more reliable sensation. In fact, the industry standard for testing analgesics is third molar removal. And there are entire warehouses in Texas where dentists remove people's teeth in exchange for research participation, because in America there's still joys of no socialised healthcare, and for that reason people reliably have to go and get treated in other ways. So these are the ways that these things tend to be done. For the other two models, for visceral pain and for sore throat, there's no really satisfactory way to do this, because they're either very seasonal or very kind of heterogeneous kind of experiences. Certainly for sore throat, even if you just talk about cold and flu, we're talking over 200 different viruses which all have different presentations. You can induce them. You can induce cold or flu by simply giving people cold or flu in a reliable way, but you then have to provide a bed for them to remain in for 2 weeks while you do your testing procedures, and also very compliant people, which is not a really good idea. And for visceral pain, you can induce it, but the most reliable way to induce visceral pain involves the insertion of a balloon into the rectum. And quite frankly, no one has yet offered me enough money in salary to do this kind of research, and I very slightly dispute the populations that are volunteering. So, again, probably not particularly reliable or useful kind of technique to be using. So unless, within this review we sort of came up with, unless people are specifically interested in looking at that pain type, they're probably rather challenging pains to look at. So we took the two models that sort of came out as being the easiest to research, and we decided to test our batteries in these. So we started off with headache. We recruited participants based on the fact that they were frequent tension type headache sufferers, so approximately 80% of all headaches can be classified as being tension type headaches, so it's really standard. It's a bilateral headache, it's a throbbing sensation, it's anything from about 2 hours to 24 hours in duration, maybe actually a little bit longer. It's moderate pain intensity, no kind of migraine aura, and that was certainly the big thing that we kind of removed was migraine. We tested people, counterbalanced, they either came in when they had no headache and then we waited on them having a headache, or we tested them when they had a headache and then we brought them back a few weeks later when they had no headache and tested them again. This particular protocol resulted in the rather strange experience of me having my mobile phone on me and getting phone calls with participants saying I have a headache and me running out of a room like I was a superhero somehow because there was an emergency headache going on campus. But that was the slightly strange way that this was done. We used our 3 good candidate tasks, as previously described. We also brought back in the flanker task to measure selective attention on the off chance that kind of these naturally occurring pains actually had more effect than the experimentally induced pain. And again, we found pain appears to impair performance on the MBAC task and no effective pain on the dual task. The effects on the switching and flanker task were slightly more problematic, because whereas in the past we found that pain increased the switch cost, so it increased that sort of selectively on where we got them to change tasks, but not when we got them to keep the same. What we found here is that participants were just generally less accurate when they had a headache, but across both the switch and the repeat trials. And with the flanker effect, again, we didn't find any increase in the size of the flanker effect. People just generally performed slower with a headache. So, not again, with the exception of that MBAC task, a little bit kind of, yet again, fairly similar to our previous reports. Not really that satisfactory findings. And I'll come back and talk about that in a moment after I've talked about the menstrual study, which we've fairly recently finished collecting data on. This was actually collected by a research assistant down at Bath. So we got 54 women who identified themselves as experiencing recurrent pain associated with their menstrual cycle. We recruited only women who are not using hormonal contraception for at least 6 months, who are not menopausal or postmenopausal, and were not pregnant. And we tested them twice. We tested them during the late luteal to early follicular phase and the mid-follicular phase. And we determined the phase order here opportunistically. So rather than kind of counterbalancing people, we think given that people are going to volunteer at kind of fairly random stages during their cycle, we'll take them during the next study into one of these two, rather than entering sort of proper experimental counterbalancing. So again, the MBAC task is slightly different here again. We get an increase in false alarms rather than a reduction in hits with the MBAC task. So we are still getting a problem with attention span, but it's a slightly different problem here. With the switching and the flanker tasks, we again get this just general impairment that doesn't relate to a particular to the task itself, but a general kind of less accurate and slower performance. And the dual task that basically hasn't worked now for four experiments, all of a sudden miraculously comes back in, and we get a poorer accuracy during menstrual pain on dual task performance. So we've now kind of tested this with two naturally occurring pain models. And we started to get the idea that acute pain seems to be having a different effect to where we do induced pain. And obviously there are a number of differences here. The intensity. So with our induced pain models, we know that all of our participants have the same at pain threshold sensation. So at their previously determined pain threshold, we've got a reliable pain sensation. Whereas for the menstrual pain and the headache pain, we just don't know that. We're getting a much wider range of sensations. So it's possible that many of our participants were experiencing pain that was of very low intensity, some were experiencing far higher pain intensity. Obviously, there's a difference in the degree of novelty of the pain sensation. So anyone coming into our lab, unless they were one of the slightly odd participants who came in and took part in pretty much every experiment that I did, these sensations were new when they came into the lab. So they had that novelty, which we know is an important factor from earlier on. Whereas, by definition, we recruited our participants for our acute pain tasks based on the fact that this was common pain to them. So it's going to be far less novel, which may explain why we're getting different effects. There's also the change in threat, and this potentially goes both ways. A new and novel sensation may be considered to be more threatening. It may also be considered to be less threatening because it can be stopped at any time, whereas naturally occurring pain, the participant doesn't know when it's going to end. One of the other sorts of things I think which is really interesting here is that, just generally speaking, we seem to be finding that people are just slower. People generally, when they're experiencing pain that they know about, just seem to slow down. So what we're maybe getting here is something which is more of a strategic set of performance. So rather than this sudden kind of incoming threat or this incoming pain that we're getting with our induced models, it's possible that natural pain, that especially if you're experiencing this often, that you just get a change in your cognitive approach. you generally change how you do tasks, and you take more time over them, or you approach the task differently. Obviously, we have to sort of say here that whether or not there are potential implications for our induced pain models, because we're not replicating our effects with naturally occurring pain with induced pain. But that's probably a bit premature on the grounds we've got 2 experiments here to go against kind of all of the previous work, but it does need to be kind of considered carefully. I'm guessing I'm coming quite close towards the end of this now, or coming towards the end of my time. So I think what I'll actually do is not go on and do the other studies, because they're quite, they're going to a lot of detail.
We've got really time for questions at the end, so you never another 5 minutes.
Go on, I'll try and talk through the other parts of this. So, okay, generally speaking, this is the pattern of performance we're getting. I won't go back over this again. But what I will talk about briefly is that we tried to take another approach to this. So one of the things I said was that the pain that we induce is different. The pain that we induce in the lab is not particularly ecologically that valid, but we need to think about this differently. So we've used acute pain models. But the other thing that that most people, certainly within the pain community, who don't have a cognitive background, is they do tend to look at these tasks that involve looking at strings of letters and making decisions about if you've seen them before. And the first question I always get at conferences is, so what does this relate to as far as like a real task? And it's a genuine thing. What do these tasks really relate to in the real world? So we tried to take this and say, okay, well let's take out of kind of the standard lab tasks, the MBAC, the flankers, all of the this kind of literature, and let's look at some potentially slightly more realistic cognitive tasks. I should say here that it's not exactly that we haven't come up with the most realistic tasks ever, but let's take it closer at least. And these simple kind of everyday everyday tasks that we perform involve a wide range of complex decisions. And we came up with sort of a couple of interesting tasks to use here. So we used the breakfast task, which is a standardised task published by Craig and Blastock back in 2006, which involves participants being asked to cook a simulated breakfast on a computer using 5 different items that all have different cooking times. And participants are required to try and finish all of the items at the same time and keep it so that none of the items are burnt, but they're all cooked. So the idea being that one item takes 5 minutes, the next item takes 4. So you've got to remember that after 1 minute of the task to start the second item. While you're doing the cooking task, you're required to set the table as many times as possible. So quite simply, drop into place plates, nice forks, spoons. And this kind of provides an ongoing task to be performed here. And you get a number of different kind of measures here. So the discrepancy between the actual cooking time for each item and the time it was cooked for, how wide the range of times it was between stopping the first item and the last item, how kind of far away from the ideal stop time you did for each particular item. That becomes quite complicated, because if you make a mistake on the first one, there's no perfect time to do the second one. And then a number of things to do with kind of performance on this table setting task. So broadly the task looks like this. This is actually the simplest version of it, so setting the table here and then cooking the items on the side there. We actually did this so that every food item appeared on another page, so there wasn't a continual update of how long the food was being cooked for, just to try and make it a bit harder. And what we found here is that we get a significant effect, or a significant impairment as a result of pain. So we use our standard induced pain model here. On the secondary task performance, so participants when they were in pain were less able, were able to set the table fewer times than participants when they were doing the task with no pain. So again, potentially here we're getting that it's harder to engage with the task, it's harder to perform these multiple tasks at the same time, and you're having to commit more mental resource to your primary task. We also get a task which was called the Scrabble task, joyfully actually designed by a guy called Steve Payne, which always makes me chuckle, in which participants are presented with 2 lists of 7 letters and are told to make as many words as possible in 10 minutes from these 2 lists of 7 letters. And you can only use 1 list of letters at any one time and switch between the 2 lists as often or as rarely as you like. And we're interested in kind of the number of words that were made per list, the number of words made overall, the amount of time spent on each of the 2 lists. So I should say one of the lists it was possible to make twice as many words from as on the other. So strategically you were better off spending about 65 to 70% of your time on the easy list and the rest on the hard list. So obviously once you start making words off the easy list, there are fewer words to be made there. And we're interested in the number of switches as well. We also asked people here to rate how they thought they were doing on the task. So on all of the objective measures, we found that pain didn't actually have any effect. So pain didn't change the amount of time people spent on each of the lists, the number of words generated. But what pain did seem to sort of have an effect on was that participants, rather than participants in the control condition rightly believed that they'd spent longer on the easy list here rather than the easy list. So they thought they'd spent more time on the easy list than the hard list. Participants in the pain condition, however, thought they'd spent the same amount of time on each of the 2 lists. So they were less aware of how they'd actually performed, certainly as far as time goes anyway. And at this point I'm going to stop, but this got me interested in time, which is where I would have gone after this anyway. So, okay, thanks very much for that.
So, is there any point in doing studies on experimental pain?
Is there any point in doing this on experimental pain? I think it's too early to throw them out, certainly. And the other thing is that, you know, we're trying to get at, or what we were trying to get at with our acute pain models, is we did recruit people who were frequent sufferers of these sensations. So I think it'd be interesting to look at people who are experiencing pains that are more novel to them and potentially more threatening. I think there's certainly a lot of other work to be done. But yeah.
Okay, but it's new.
It's, yeah.
Opportunities. Questions first. Okay.
I was just wondering, when you're doing stuff like headache, how do you control for other things that could lead to both headache and poorer performance on those cognitive tasks,
such
like
as
tiredness or low blood sugar and stuff? All those things can lead to the cause of the pain as well as affecting the tasks.
We weren't able to certainly with blood sugar, we didn't take that into consideration. We did have it so that we tried to test participants at sort of approximately the same time of day. We only used headaches that were new on that day. So it shouldn't be a situation where they were in pain overnight and failed to sleep, and therefore that was having an effect. Obviously, it is a possible factor, and there are a number of questions. Just thinking about what you're saying there, we didn't seem to give them a measure of sleepiness at the time, which potentially could have explained some of our effects. But so that there are certainly other things which might be involved in some of those effects. I think there's a lot of work still to be done to draw some of that out. I actually know that they're starting to do another study of headache, which will be a larger scale experiment to try and sort of look at some of these effects, covering more factors now.
It's really interesting to try and see exactly what factors.
Just adding on to that, actually, if you could sort of say what's it might be interesting because it seemed that in the more natural pain, acute pain stuff that you're doing, we were sort of reporting general kind of slowing as well.
Yeah.
And so that you looked at general kind of speed measures, which maybe some sort of general physiological, almost kind of slowing, I suppose.
Yeah.
Because there are, as I'm saying, kind of a reason for the pain, source of the pain, which is another thing that might be behind it.
Yeah, I certainly think it's something that's a useful thing to have in there. And No, because it just it completely didn't come out during the earlier phases. One of the big challenges pragmatically with this was trying to keep the task short enough to actually make it possible for participants to perform them. And actually during the kind of earlier piloting phase, we tried to look at more factors and just found that we ultimately ended up with absolutely null data just as a result of the rules of having too many things in there at the same time. But I definitely think that a short measure of processing speed or reaction speed to go alongside potentially that fragment might be useful.
I was wondering what your sample, what your population was like for your experimental threat task, do you recruit your participants?
So all of the participants for all of these, I should have said this, it was a student population across the board. So.
Were they a lot from psychology students?
No, for the threat study actually they were primarily not psychology students. We did get a handful of first years coming in. We did try to avoid recruiting psychology students for that, so it was from other parts of the university, because psychology students obviously are notoriously suspicious of anything. So
were they sort of familiar with?
No, we actually at that stage we were not recruiting, because obviously we knew that participants who come and taken part in our studies beforehand would know that the machine didn't test skins resistance and would know all of these kind of other things that we were all of a sudden telling them completely different sets of instructions. So they were all completely naive participants for that study. So although some of them may have taken part in other studies by other groups, they certainly weren't aware of ours.
I know from my past study that I got some people who had done quite a lot of research studies before, and some people who had really never done a study before, and they were quite nervous coming into my study, which didn't involve any pain or anything, but those who really had never had any experience of those situations were a lot more nervous anyway, so I wonder whether...
it is possible that we just weren't able to increase the level of threat, that they had a level of anxiety that we couldn't manipulate our task instructions, and that was just a factor there. I mean, the threat instructions that we used are based on a number of previous studies, which have primarily been used to look at the kind of the opposite effect, so at the level of kind of reduction in pain sensation as a result of distraction, and are fairly reliable within that literature. So we would expect that these instructions would work, and they were certainly, like I said, they were certainly believed by participants, even though they didn't seem to change their levels of anxiety. So,
this is going to show my complete lack of knowledge about the area of pain.
Mm-hmm.
Presumably, if people are in pain when they come in to do your tasks, then their body would have initiated some kind of response to this, so they'd be naturally releasing endorphins, norepinephrine, and dynorphins to try and counteract the pain.
Yeah.
Would this be one of the reasons why their attention's impaired? So, if you've had morphine or something like that, your attention is massively impaired and you can't concentrate on anything. Is the fact that your attention is impaired when you're in pain because your body's already initiated this response, or is it more a psychological thing, like you're dwelling on the pain because you want to stop the pain from happening?
Yes. No, I mean, it's a good point. I mean, we don't know how much of this kind of, the medium term, let's say, rather than long term effects that we're getting here might be as a result of the body combating the pain itself. So it might just be that this endogenous opioid system is having an effect on performance, rather than it being kind of the pain per se that's having an effect. I mean, either way, it's an interesting way, kind of experimentally, and something which I hadn't thought about before, but I'm doing quite a lot right now, and certainly will be. That's going to be potentially different to our induced models, but it's certainly, that's going to be something which is going to be common when these acute pain conditions, and that's kind of that's what the point of this grant was, to look at those acute pain conditions. So it's going to be a factor when it comes to sort of considering the degree of attentional interruption by pain. So I still think it's kind of reluctant because it's not clinical population, but clinically relevant. the models, but I definitely think that the independent factors of that compared to the pain physically, I think is a really interesting point. Something worth looking at.
Right.
Dave, I've got no knowledge of this topic, obviously, but I just wonder, is there some way to manipulate perceived threats realistically? I don't know, I mean, women who might be sort of going through period pains and awaiting a HIV test result or something.
I mean, as far as manipulating threat, the other approach that's often used is to basically try and find people who generally find pain threatening. So to use, as I talked about at the beginning, something like pain catastrophizing. So your tendency to think when I'm in pain, rather than it just being something which is transient and passing, just a normal part of the world, that every pain is actually an impending sign of doom. So you can certainly do that, and that was one thing that we did kind of consider looking at was just getting people to fill in catastrophizing scales and kind of dichotomize them on that. We actually did it with I think the headache study, and found that people's level of catastrophizing didn't have an effect on the size of the sample there. As far as looking at at other groups who are in pain and potentially awaiting test results for something, I don't say there's nothing that I'm aware of that has done that, but I don't see any reason why why in practice it couldn't be done. So
I mean, that's one scary scenario when you've got sort of HIV results that might be positive. That's a highly threatening scenario.
Yeah.
And that might actually have an impact of some sort.
Yeah. I mean, again, you're getting into something which is moving away from necessarily kind of the fear about the pain itself, more into a fear of a medical diagnosis, which is potentially something which is a slightly separate question, I'd say. But I mean, I certainly think that if you've got concern that your pain may be an underlying symptom of something much more serious, then the amount of attention you're going to be giving that pain will be far greater, and therefore the amount of attention you'll be giving something else will be far less, I would imagine. So
Hey, it's a quick question about kind of building on some of the questions before. We know that mood, particularly negative mood, affects attention and cognitive function. And my question is, to what extent does it make sense to try and decompose mood from pain, or would you like to treat that as part of the pain experience itself?
I think trying to look at it, certainly in these early stages, and trying to sort of remove mood from the question, and certainly almost all of our studies are within subjects. So, participants we wouldn't expect their mood to be massively changing during the.
Wouldn't you? Mood is a kind of state-related thing.
Yeah, I mean, I suppose it potentially is in there. And, we have done. Again, with these studies, we have included a measure, kind of repeated through the thing, a simple VAS of how anxious are you at this point. And we found that doesn't seem to be, kind of a major effect. We use that in the threat study to see.
But do you treat it as a confound? Do you treat it as part of the experience?
We've sort of ignored it up to now, rather than anything else, and tried to sort of, not really think about it as being, in these early stages, something where we're trying to look at pain on its own and its effect. But I think going forward, especially given that the data that we got was interesting, if not entirely the most kind of stable set of, I'd love to be able to stand up here and talk about an amazingly stable set of findings that ran across 5 years and resulted in, a really definitive answer. But I certainly think, we're looking at other factors, things like mood and its relation to kind of these performance issues is going to be something hugely important. I mean, the other big one that I'm interested in looking at some stage is the amount of effort that people are putting into the tasks. It never actually came out as being significant, but one thing that we often kind of observe in there somewhere is that men often actually perform better in pain than out of pain. And I don't believe that's really a kind of a genuine that pain makes men perform better on tasks. I think that 18-year-old male students are idle quite often and are wanting to prove that they are good in pain. And I think, so there's so many factors that are coming in here that you're putting people in a test environment where they're performing something for a very brief amount of time. And if we were able to test people for sort of 2, 3, 4 hours on doing these kind of things, that degree to be able to kind of concentrate through it for that amount of time, I imagine would be, would disappear fairly quickly. Whereas on tasks that I think are no more than about 7 or 8 minutes long, you can potentially focus through it and deal with it through other mechanisms. So.
Well, I think what David has clearly shown is what I started off saying, that's how multi-dimensional pain research is. It brings in everybody from all different disciplines, and brain and behavioural sciences have something to contribute to pain research. Hopefully we'll be able to build that more into our research ethos. So thank you very much, David. And there's more lovely mince pie.